Okay, good afternoon, everyone. Well, thank you for joining. Welcome all the 55 registrants and the participants to this webinar, to this Health Equity Initiatives webinar with Dr. Renata Schiavo and Eleanor Cooney on implementing systems level change for health equity. A summary of the partnership summit that was held on February 25th and 26th, 2016 in New York City. I'll be your moderator. My name is Frizo Van Riesema. I was asked to be on the Health Equity Initiative board after contributing as a co-chair for the Public Policy Committee, and I participated in the inaugural Health Equity Initiative Summit as a Health Equity Initiative member, as well as a roundtable presenter from the public health perspective with my MPH from Johns Hopkins, as well as from the commercial angle as a health communications and patient engagement professional. So I plan to moderate the webinar with a brief introduction of the organization and two of its board members and speakers. They'll both speak for around 10 to 12 minutes, followed by two jumpstart questions from me and a selection of questions from you, the participants. If we do not have time to answer all your questions on today's webinar, we'll gladly address them through email or a phone call. Now, Health Equity Initiative is a nonprofit membership organization. We dedicate resources to build and sustain a global community that engages across sectors and disciplines to advance health equity. Some of the ways that we do this is by building community, capacity, and communication resources in support of the work and efforts of our members and the broader community. So we seek to encourage the development of a multidisciplinary social movement that's engaged with and works towards innovative solutions to health equity issues via systems level change. We're unique in our efforts to bridge the silos among different professions, communities, and different stakeholders in health equity issues so that together we can build one community for health equity. Our membership, we have a strong Health Equity Initiative membership with benefits that include access to valuable content online, some key opinion leaders, special events, webinars like this, social events in New York City, just to name a few, for $105 per year as an individual, which really supports this health equity advocacy and awareness building. You can discover more details on the membership benefits at healthequityinitiative.org under Join. And yeah, as a member, you'll be reminded and asked to participate in the 2018 summit, as well as committees leading up to the summit if you're interested. So please contact me or one of our passionate interns to explore ways in which you'd like to be involved as an individual, student, or a corporation. So in terms of the summit, implementing system level change for health equity, it was really a partnership summit that happened earlier this year in New York City. It attracted over 100 participants from multiple sectors, communities, including public health, healthcare, architecture, urban design, transportation, parks and recreation, information technology, and community and international development. And we've built a support from more than 5 sponsors in this event, 4 plenary sessions, 8 roundtables, and 4 interactive consensus workshops. There were also 12 posters from academic medical centers and national collaboratives, including the New York City Department of Transportation, and others covering themes focused on communication about health for policy and social change, and awareness building, patient engagement, urban planning, socioeconomic development, and how all of those interplay with health equity. In terms of our presenters, I'll first introduce Dr. Renata Schiavo, our founder and president of the board of directors of the Health Equity Initiative, as well as a senior lecturer from Columbia University's Mailman School of Public Health, and also a principal of the Strategic Communication Resources Organization. And then our second presenter, Eleanor Cooney, who's also a Health Equity Initiative board member and public relations and public affairs professional. So before Dr. Schiavo shares her insights on the summit, I'll provide a background into her impact in public health, international health communication, with a specialist and a focus in healthcare, global health, public health, and social innovation. She has over 20 years of experience in a variety of settings, including the United States and several countries in Europe, Latin America, and Africa. Really a pleasure to speak with about her travels always. She's currently the founding president of Health Equity Initiative. She's also an editor-in-chief of the Journal of Communication in Healthcare, and a founder and principal in a strategic communication resource organization, a global expert consultancy, which she established back in 2004. Dr. Schiavo was recognized as one of 300 women leaders in global health in 2015 by an initiative of the Graduate Institute of International and Development Studies in Geneva. And in addition to her academic and research expertise, Dr. Schiavo brings to her courses and interactions with students her extensive experience as a public health and a healthcare practitioner and entrepreneur, as well as her passion for making a difference in people's health and lives and addressing health disparities. And our second presenter, Eleanor Cooney, is also a Health Equity Initiative board member who has spent more than 35 years in the practice of public relations and public affairs. She was a co-founder of the Cooney Waters Group, which is a communication specialist group in the areas of health and science. And since 1992, New York City-based agency has served the strategic communication needs of clients in healthcare, nutrition, pharmaceuticals, biotechnology, and health advocacy in the U.S. and internationally. She's directed crisis management programs around issues including animal research, biotechnology, and food product safety, and U.S. vaccine supply. Among her specialties is the design of strategy to stimulate consensus and coordinate action on a given issue among multiple sectors, including policymakers, medical opinion leaders, healthcare providers, and consumers at the national and state and international levels. So with that, I'm excited to hear from both speakers regarding their unique perspectives on health equity and the summit. And with that, Dr. Schiavo, will you start us off with your presentation?
Hello, everyone, and thank you for joining us this afternoon. This is the first of a series of webinars to spread around the findings from our 2016 summit. I see on the list also some people who actually participated in the summit. Welcome back, and please feel free to also share your perspectives during the Q&A session. I wanted to say just a few words about the summit for the ones who were not able to participate. This was sort of first of its kind in the health equity movement, and pretty much in line with our concept at the Health Equity Initiative of building a multi-sectoral and multidisciplinary community for health equity to create a place where everyone feels that health equity is our own issue, is everyone's issue. And in fact, the summit was very diverse and brought together community leaders, professionals, and students from multi-sectors, of course, the usual subsets like public health or healthcare, but also professionals and students, community leaders from architecture, urban design, IT, healthcare, and many others, faith, and many others. The idea of the summit was to discuss the barriers that contribute to health inequity and to continue to build and sustain our movement for health equity by exchanging ideas on how to advance our mission. There were 4 more teams to the summit, which were all designed to focus around current themes in the health equity movement. The first of these themes, socioeconomic development and health equity, sought to explore how can we also make a link between health equity and the ability of everyone to thrive and prosper. We all know that health equity is a social justice issue, but in order to engage more allies, we need to make other arguments that make it relevant to everyone. The other team was related to urban design and health equity and the connection between the urban and physical environment to basically the ability of people to stay healthy and cope with disease. And of course, throughout the summit, we explored the role of community and patient engagement in the health equity movement and how we can better communicate about health equity with a variety of different players. The summit included some traditional sessions in which basically participants heard from experts from multi-sectors and disciplines, but very exciting, they participated also in consensus workshop in which they developed an agenda for system-level change through consensus building and through discussion. There was a poster session, and at the end, many pledged new partnership. This is a snapshot of the summit. We had close to 115 participants over 1 day and a half, and as you can see, the people represented really different sectors and kind of organization, from nonprofit to academia to government to foundations to hospitals to community leadership and so on. This is a brief sample list of the organization who actually participated in the summit, and as you can see, they range from healthcare organizations, like, for example, the UTMB Center to Eliminate Health Disparity, to basically the New York University School of Medicine, but also non-traditional players, like could be the Robert Fulton Terrace tenants, which represented a group of tenants in the Bronx, and also the Bristol Myers Squibb Foundation, the St. Louis Park and Recreations, department, and a variety of international organizations like UNICEF and Archive Global. I want to start by talking about the key messages from plenary and roundtable sessions. The first one, which is something that we have been also disseminating and talking about at Health Equity Initiative for a while, and it's really at the core of the overall Health Equity movement, is that there is more to health than healthcare, and that in other words, there is not going to be an opportunity to stay healthy unless we remove some of the barriers that prevent people from staying healthy. And this means that, for example, we cannot ask someone who lives in a food desert to eat healthy if there is not the opportunity for them to purchase and consume healthy food, and so on. Also, one main theme of this from the plenary roundtable session, that basically all of these different issues, health, education, income, poverty, current behaviors, policies, they are all interconnected and all affect health, and we need to collaborate much more systematically with different sectors in order to advance health equity, because although we made progress, much more is needed to counter long-standing drivers of poor health, poverty, and inequality. And also because we are an organization that has been establishing and promoting a community-driven approach to health equity, this also resonated in a lot of the plenary and roundtable session through what our speakers shared with our audience. And I want to close the slide with this concept of equity being efficient. In a lot of settings, the current wisdom is that equity may not be efficient, that reaching the underserved, reaching the poor is sometimes too difficult. But actually, many of our presenters argue the opposite point, that it's indeed efficient, because we have not only a number of new technology and new strategies to reach everyone to using inclusive approaches, but also we have an understanding of the value proposition of health equity. We know that healthy communities means also healthy business. We know that healthy communities means safer communities, and communities that are safer safer for all. So the concept of health equity being efficient resonated across a lot of these presentations. Other key messages were around, basically the core questions of the summit, which is what are the implication and action areas of a system-level change approach to health equity. And obviously, the first item is about identifying and addressing structural injustice. A lot of the presenters and participants spoke about the role of different determinants of health, and also communicated the need of finding safe forums for speaking about issues of race, poverty, class, privileges, discrimination, and so on. And in fact, our next summit will be focusing also on many of those issues more specifically. And also the importance of embracing the interdependence of the multivariates and factors that contribute to social discrimination, to poverty, to health inequities, and so on, and being basically having a more systematic approach to measuring the impact on quality of life, on communities, on patients, on the ability of communities to thrive and prosper, to have access to services and information in a timely and equal way, an equitable way. Also, the other thing is to prioritize the improvement in living conditions via new approaches that bring in also the unique perspective of urban design and architectures. A lot of our speakers, especially in relation to the urban design and health equity team, they were practicing architects or urban designers, and they spoke about a lot of the intervention, like, for example, investing in healthy housing that may make a difference in eliminating health disparities. Continuing on the implication for an action area of a system-level change approach to health equity, this is also a main passion of mine, but also of many of the speakers who participated in the summit, is the importance of raising the influences of communities, disadvantaged population, and other voices on health equity. The summit discussed a few methodology for making sure that both policy and practice are implemented by the needs and input of average citizen, reach the poorest and most advantaged, and also engage communities and key stakeholders. I personally led a workshop in which I spoke about some of the lessons from developing countries that can also inform such efforts in the United States, especially considering that some of the characteristics of vulnerable and underserved population across different settings and countries tend to be similar, and they are related to a history of poverty, social discrimination, lack of access to services and information. One particular roundtable also focused on mobilizing the next generation of health practitioners and young people in general, and using specific methodology to actually engage them in the conversation on health equity. I'm going to pass the workshop to Eleanor, who is actually going to be speaking about the consensus workshops. Eleanor?
The consensus workshops offered the summit participants a chance to really focus down on particular themes of the conference. As Renata said, these were the socioeconomic development, communicating on health equity, community and patient engagement, and urban design. And in doing so, they were able to bring their knowledge, experience, and perspectives to bear on identifying priorities, strategies, and action steps to advance the concept of health equity. Always the focus stayed on the human, the people at the center of the health equity concern, both those at the community level and patients and individuals, healthy and unhealthy individuals themselves. And it really was intended on also to jumpstart the effort, which was everyone recognized as clearly urgent, was to develop collaboration and partnerships among those who could bring the realization of the health equity vision to fruition. The facilitators for the event had been specially trained to guide the group toward the outcomes of establishing and organizing priority strategies and action steps, and also through the use of small group methods that Renata Scalo had developed and used productively in problem settings around the world. Friso? Friso, can I? Okay. Socioeconomic development was the first, and I think just about everyone involved in any aspect of health equity recognizes that health equity is a vital issue of social justice. But health equity has benefits far beyond the substantial improvements in individual ability to be healthy. It also benefits the whole. It increases economic well-being and the social capital of our cities, communities, and neighborhoods. Using a health equity lens on the community, we recognize that social and environmental factors that contribute to health disparities. There's poverty, race, socioeconomic status, gender norms, to name a few. But it's equally important to recognize the obverse. The community that we talk about is more than residents. It's businesses, employers, workers, it's schools, teachers, churches, clergy persons. It's everything that goes into making a community. And is in that respect that health equity can actually be a benefit to all. It enhances the vitality, if we achieve it, it enhances the vitality and prosperity of our communities, towns, and cities. And we need to, it was recognized, to sharply define that relationship between a healthy person and a robust community. And that was the chief priority identified by the workshop participants. And if we're to establish health equity as a social norm, we need the buy-in of all sectors, that this is a social investment with significant returns for the entire society, that health equity is in fact efficient. We need to step up our advancement of the concept first among those health and design professionals already working in health equity, by conducting innovative research as proof of concept, by developing allies among professionals and advocates working in related issues, and by seeing that this messaging is crossing over among all sectors of the public and private endeavor, all the people we're going to need on board to make this happen. And to do this, we're going to need to cultivate champions and allies outside of public health, to combine the knowledge and social capital at the grassroots level with the material wherewithal of those at what we call the treetops. That is a wealth of ideas brought together with the resources and political will to bring them into reality. This is going to take extensive public debate, we recognize, and perhaps most critically, a set of performance indicators developed that everyone can see and understand in terms of what the goals are and what the progress is toward those goals. Friso? Okay. Our world, this country and all countries, is becoming ever more urbanized. Our environment is now chiefly a built environment. As we design, we will live. For health equity, this means infusing the idea of how to make a healthy community, make it possible and sustainable, and bring it into every aspect of urban policy and design and urban planning. Every professional involved in any of these areas must be our active ally. We need a particular and intense focus on investments in meeting the needs of at-risk communities and an accessible and shared vocabulary for understanding and addressing design issues in the community itself. And to do this, we're going to need to build working relationships and trust with those who are in turn most trusted by the community, the gatekeepers. We need to look to invest those currently underrepresented in the planning process, the planning professions, and also the processes. We can encourage people to enter those as careers, but we can also tap the ground experience, the on-the-ground experience of community members in tackling design issues from a health equity perspective. Finally, we need to foster development of a shared vision of the value of community participation through programming that actually enables and nurtures that participation, not just infrastructure. Friso? Okay. Health equity is not a readily understood concept. I think we all recognize that. Its breadth and complexity makes its communication a challenge. Yet the great variety in the levels of awareness, acceptance, and concern for health equity make it imperative that we really put our shoulders to the wheel in this area, that we define health equity and why it's important for every major stakeholder group, and use communication by sector to affect social and policy change. Emotional intelligence was identified as a chief need here. We need to understand how the particular audience we're addressing, the particular sector, thinks and what their concerns are, and how we can work together for mutual benefit. Not everyone feels well equipped for this task and recognize. So building communications capacity will be essential, how people can use this in their own work and also their sort of missionary outreach to other sectors and how to do this effectively. We'll also need to research our potential allies and champions within the context of their stakeholder group to sort of identify those people who might be able to carry this forward in the respective stakeholder groups. Then work collaboratively to develop communications messages and approaches that address the needs and concerns of all the groups relative to health equity. Friso? The final consensus group, community and patient engagement, is essentially the heart and soul of the health equity movement. We need to build relationships that endure that promote long-term participation and shared decision-making in every aspect of interventions, and that's too often neglected. To get there, we'll need to empower community members through training and the involvement of the community from the point of inception of any project, in order to bring those projects down from what's often the 10,000 or 30,000 foot level right into the community where people can see it and have their input into it before it's effective. We'll need to design and deliver the resources and technical assistance necessary to get this done. We recognize that there's a good deal of work need to be done here. And make sure we have mechanisms like community panels for input right along the way. And so, as well as, and this goes right across the board, involving all the stakeholders with the community itself, because unless this is a multi-sectoral effort, we're not going to achieve the vision for health equity that we all share, I believe. Okay, thank you.
As Eleanor said, obviously health equity remains a very complex concept for many people. This is due to the complexity of the concept itself and the fact that there are so many determinants that contribute to the ability of people to stay healthy and thrive and prosper. And it's also likely to be community specific because different communities, different stakeholders may face different issues and barriers to health equity. So ideals need to be defined, may relevant across different profession, community sectors, making sure that everyone arrives at its own definition of health equity, as well as their own priorities in achieving it. The other thing is that we need to recognize, this is another main conclusion of the summit, and embrace the interdependence of the drivers of poor health, poverty, inequality, which is an essential step not only for the health equity movement, but also for so many social justice issues. Health equity is a lens, and it's a lens through which we can also address poverty, we could also address social injustice, racism, and many other social justice issues, just like how these other issues are very connected to our ability of achieving health equity. At the heart and soul of the health equity movement, it is community and patient engagement, which is a strategy that I have used and others have been used successfully to advance so many different causes across different country settings and population. And this needs to go behind information dissemination. When we think about community and patient engagement, very often we think about using the expertise of community to disseminate messages. But actually what we're proposing here, and what was one of the conclusion and recommendations from the summit, is to actually use the strategy of community and patient engagement to engage communities in the design, implementation, and evaluation of all intervention, so that ownership and sustainability of all of them will be increased by their participation, input, and expertise on their needs and solutions. Other key conclusions, it's obviously the importance of enlisting a wider group of participants in designing a healthy city. The importance of the physical environment and urban design to advancing health equity is very well established, yet both summit participants within other studies and experience, we know that this is not a well-known fact among practitioners in public health, healthcare, community development, and other fields. And also people need the tools to be able to participate in urban design process as non-designer, just like urban designers need the tools for engaging communities and other non-designer in designing city that allows for a healthy life. A number of strategies were discussed at the summit, and we look forward to continuing this conversation in future webinars. Capacity building and training was another key recommendation for the summit, and this is a prerequisite for action both within health and non-health stakeholders. The summit also identified several areas for capacity building and training. Eleanor already mentioned the need for communication capacity and training, but also for cross-sectoral collaborations so that we can learn about the language and the objectives of different kinds of organizations and effectively collaborate to advance health equity, or resources a tool to enable participation, as I mentioned before, in urban design processes, or empower community to participate effectively in health equity intervention. Finally, one other recommendation was the importance of health equity-related efforts in fields outside health-related profession, which was a major theme and topic that emerged from the summit. We are really talking about a shifting social norm, encouraging innovative thinking that can address the health disparity that plague our communities and cities. And this really requires everyone's involvement from different sectors, from different disciplines, from different walks of life. So what we're really talking about is about considering and implementing a new concept of community. Very often we think of community just about community residents, but actually community is all of us who live in a geographical area, work in a geographical area, operate in the geographical area. It's about business, the institution, the municipal service, the policymaker, the government service, the local stores, the parents, the schools, all of which have reasons to care about the health and prosperity of a specific neighborhood, community, or city where they live, work, or operate. And only by bringing together this kind of community, we can move forward with the health equity movement. So I want to close with a call to action. I think that what we hope that you would do, we will use the findings of this summit to actually, for the conversations and the actions that will happen in your own organization, recognizing that the time for health equity is now, that there's never been a much more pressing moment for us to start tackling the health disparities that are preventing so many communities to thrive. And I wanted to leave with some practical steps to start a conversation in your organizations, like identifying champions, whether it's in your organization or your own community. Discuss and assess what is the value proposition of health equity really for your organization. It's about a healthy community means healthy business. It's about healthy community means safety. It's about healthy community means more prosperity for all. What is the value proposition of health equity that is specific to your organization or community? By starting with this question, it's also most likely that you will be able to engage more players. Obviously, we need to focus on capacity building and training in order to continue to health equity movement and really empower everyone to participate effectively and engage in partnership about sectors. This is a process that requires a lot of humility, both culturally, both organizational humility, both community humility. So we need to be open, build trust, inclusive of vulnerable and underserved population, recognize the expert in everyone, and engage communities and other stakeholders in all phases of all intervention. So we hope that you will decide to join the movement and that the findings and information from the summit will be helpful to you in your endeavors. And I want to close with acknowledging the other summit report co-authors, who in addition to me and Eleanor also include Divya Padagonkar, Carmelo Cruz-Rice, and of course the many colleagues at Health Equity Initiative who have provided input and suggestion and feedback. I want to also acknowledge the 2016 Summit Organizing Committee, without whom the summit would not have been possible. Their names are here on the slide, and our Summit Allied organization and our fantastic sponsor, facilitators, and participants. And with these, I just give it back to Friso.
Thank you, Renata. Thank you, Eleanor. Great insights and summary of the summit. This is the portion of the webinar that will go through some questions that the participants had, as well as some questions that I would love to jumpstart the conversation. So if anybody on the webinar would like to ask a question, please go to that chat function and type your question there, and we will ask Renata and Eleanor to address those. One of the questions that I had, and that was also mentioned in the chat, is around the participants in the summit. So my question, which I'll add the participants' question as well, is which sectors and stakeholders would you really like to see more of at the table, be it at the plenary talks, the roundtables, the interactive consensus workshops, the poster. And the question that was asked in the chat was, if how diverse was the audience, and were the voices of the disadvantaged, the vulnerable populations, were they present?
Thank you, Friso, for this question. I think that the summit was fairly diverse. We had a lot of community leaders, and I think one of the most exciting things for me about the summit was to see community leaders working side to side, close with advertising executives or with foundation executives, with the government agencies and other, and some of the community leaders being represented tenant association or patient association or people in education and disabilities and so on. To your question of what we would like to see more around the table, I think one feedback that we received from participants was about having more government agencies around the tables. We had several government agencies. We had the NIH, we had the Department of Health and Human Resources Region 2, we had other key players around the table, but they would like to see also more government agencies. And of course, I think that also in light of the recent IOM report on the role of the private sector in health equity, I think that it would be great to see even more participation from corporation and different kind of business. We had different business represented at the summit, but we definitely would like to see more getting involved in the health equity movement.
Fantastic. And another question to jumpstart before I get to another question from the audience, a question for Eleanor. Which recommendations from the summit really speak to you most as a public relations and public affairs executive? It's a very important phase for health equity right now to build that awareness. What would you say were some of the recommendations from the summit, from this multi-stakeholder group, as well as some of the disadvantaged at the summit?
I think it really is getting this concept across. Number one, what it is, what its components are, and this is not the simplest task in the world, which we recognize. And sort of getting that to, maybe stratifying the groups that we're targeting initially, and sort of make an effort really to get to them, find out what they do and don't understand first, then find out what they do and don't understand, accept, and shape our messages and our approaches around that. Because unless we get everybody at least to the point where they can say yay or nay, and many people aren't at that point yet because they don't really get this, I think that's key to that in terms of communication.
Thank you, Eleanor. And I'd like to go to a question that Renee asked. How does the Health Equity Initiative movement work with stakeholders outside the U.S.? And I know Renata, you've been very involved with this. And a second piece to that question was, are there researchers in the U.S. that are doing health equity research outside the U.S.?
To the first question, thank you, Fris, and thank you, Renee, for asking it. I would say that 10 to 50% of our membership base is based internationally, or based in the United States, but representing international organizations. And the way that we work with them is similar to the way we work with other members and broader community here in the U.S., which is basically making sure that our resources cross boundaries of countries and and information, and we also making sure to that our resources and events gather also to them. We currently have members that represent healthcare or international organization in places like Australia, New York, the UK, and one or two in Africa also. And we feel that we would like to expand on our engagement with this kind of membership. We have always making sure to incorporate also speakers, just at our summit from, for example, UNICEF, Archive Global, the Bristol Myers Squibb Foundations, who all represent also the interest of different countries. Not the list of countries is not on our website. We have welcomed on our newsletters organizational members from different countries. So if you go to some of our past newsletters, you can see a partial list of that. But it's a good idea. Maybe we should put it in our website. So thank you for proposing it. I think that the other question was about whether there are researchers who are part of our membership who work also with researchers outside. I'm not sure I know about the answer of that question. I know that a lot of our membership is also in academia, and many of them are engaged internationally, but I cannot comment more on that.
Wonderful. And so there aren't any other questions from the participants, but selfishly, I would love to ask a question and bring up, I think, a very valuable point. From a cultural anthropology perspective, I'm interested in what Dr. Proctor said. He's the Senior Advisor to the President and Director of Achieving Health Equity Portfolio of the Robert Wood Johnson Foundation. And he mentioned a theme called a culture of health. So would either of you elaborate on why you agree or disagree that investing in this culture of health will reduce health disparities?
I can take it, and I will be very happy also if Eleanor can add a perspective as well. But I think that building a culture of health is very connected to building a movement for health equity. A culture of health, as Dr. Proctor himself defined, means getting to a point in which we getting healthy and staying healthy become a fundamental social principle, a social value, a social norm in American culture. And I think that we now see in different fields the importance of changing social norms, so changing values, so making sure that everyone actually contributes to the kind of social and policy change that is needed for people to value health as a fundamental, not only right, but something that we do together. So I feel that this was, a very good mention and presentation by our keynote speaker. And I think that building a culture of health is intrinsically linked to advancing health equity and also to counter the long-standing drivers of poor health, poverty, and inequality.
If I can add something too, I think making a culture of health a social norm will make it easier to address the needs of at-risk communities, because they won't be seen as the recipients of our beneficence, but actual participants in a society-wide set of behaviors that everybody should be able to perform.
Wonderful. Thank you. Well, that concludes the question session. I'd just like to conclude by thanking the presenters, thanking the participants, and concluding that health equity movement is here, and we're making progress. For the most part, it still remains in this realm of a few health-related and academic sectors, but because of its significant impact on the current and future generations, health equity is a key social justice issue that demands that the sustained engagement and investment of multiple stakeholders at different levels of society so that we can all work together towards eliminating these health disparities. And you've taken steps towards building awareness for health equity, and if you haven't already, please become a member, advocate for health equity with us, and encourage your friends and colleagues outside of healthcare to really see the value in elevating health literacy and access for all. That concludes the webinar. Thank you very much for your participation, and hope to see you on a future webinar.